Olá pessoal, nós estamos aqui no EAU in situ e é grande prazer receber aqui O Brien. It's a very nice pleasure to have you here with us, with Brazilian neurologists. And we would like you to tell something about, after the Carmina trial, we have some issues about, the both arms of the trial. And regarding to citorreductive nephrectomy, what you would like to address Brazilian neurologists of doing citorreductive nowadays?
Okay, thank you. Yeah, I mean, the Carmina trial does change things. There's no doubt about that. And I think urologists can't just rush to the operating theatre and do an operation. That would be wrong. And I'm not standing here suggesting that's wrong. But I do we still think in our department that citorreductive nephrectomy up front has a role. And we think it's in the people with better risk disease. Our concern about the Carmina trial is that the patients had very poor risk disease. And I mean, one of my colleagues said, was this a trial of surgery in people who should never have been offered surgery? Were a lot of people in France getting surgery off trial who were relatively good risk, and the only patients who went in the study were people with poor risk? That's our main concern. So, and we see a lot of patients with very large primaries and very small volumes of metastasis or equivocal metastasis. I think sometimes the imaging is not clear, is it? And in those situations, we tend to revert to surgery rather than not. And our results, I think, would back that up. But I think doing a citorreductive nephrectomy for somebody with a small kidney tumor and multi-site metastasis is not sensible. And we've framed this as a single: does the primary need treating, or do the metastases need treating? Multi-site, multi-place metastasis needs a systemic treatment. But a large primary with a very small volume of metastasis, we would say control the primary first. That's how we do it. Pragmatic, and we haven't had cause to regret that. The other reason we do it is that I think it also can buy patients time off systemic treatment. So a lot of the arguments in meetings tend to be, well, if people have the surgery, they never get the systemic treatment because they're too ill or they have complications. That's very rare in our practice. That's about 3%. It's not the 20% that's often quoted. Whereas what we find, if you do a citorreductive nephrectomy, a patient can have a good deferment, so they don't need systemic treatment straight away. They can have a period of observation. We can watch the situation. And I think that's a good thing. If they can have 12, 18 months off systemic treatment, that may be a very good thing. So we call that a good deferment rather than a bad deferment. A bad deferment is a deferment because of complications. A good deferment is a deferment because you don't need it. So those are the reasons we do it. And, we haven't had cause to regret that.
There's a nice curve. O Brien, he's a surgeon from Guy's and St. Thomas Hospital in London, and he showed us a very nice arm of. Can you tell us about this arm? It's okay.
Well, what we did was a nice thing. We took one of the graphs from the Carmina trial with the curves of the surgically treated patients and the sunitinib alone patients, and we superimposed our own Kaplan-Meier on top of that, and it looks very different. If you carefully select the patients for citorreductive nephrectomy, the outcomes look very different. Median survival of 36 months, which is... I think the other problem with, as I said in my talk yesterday, the other problem, of course, is that the systemic treatments are changing, aren't they? And, that presents problems for all surgeons in that the systemic treatment is no longer sunitinib. So does that make surgery less relevant or more relevant? We're not sure. It's as if the practice is always one step ahead of the evidence, which presents problems for us.
Of course, and how regarding to patient counseling, how can you address this? Just for us to say, how can you address this type of patient when you are dealing with what is the best option for him?
Yeah, I mean, I think it would be an outrage not to present both options.
Of course.
I think you have to present both options. How I do it is I present both options. I set out both options. And people have come to see me for an opinion. I say, you may want to know what my recommendation is. It's not an instruction. It's not a demand that they have that. But you've come for my opinion, and I'm going to give you my opinion. My opinion is that this, on balance, would probably be the best thing to do. And so I think that's the frame in which one has to construct this, because there is uncertainty. What I teach is that you must be positive about the fact that there is uncertainty. So sometimes doctors present uncertainty as they're uncertain. They're dithering. They're not sure. They're not sure what to do. I'm not really sure. So I think you can be positive about the fact there is this course of action or there is that course of action. Both have their merits, but on balance, I would recommend this or that. I recommend lots of patients to have systemic treatment first. I think what we don't know in metastatic disease is what the place of a deferred citorredutora nephrectomy is. We don't know. I mean, we do it sometimes, but we don't know whether it's a good or a bad thing. So there's still some very big unanswered questions, aren't there? There's still some very big unanswered questions. A lot of patients in the Carmina trial had a nephrectomy who were in the systemic treatment arm. They just had a deferred nephrectomy.
Of course.
I think it's 30% of the patients who survived into the second year actually ended up having a nephrectomy.
So thank you so much for having you, and it's delighted to talk to you.